MRIs have lots of checklists and things that you have to ask patients before they go to an MRI. Have you list off any sort of absolute contraindications for MRI?
Like shrapnel or metal that's not MRI compatible.
Yep.
Sometimes if you've got, I think we found that if the two pieces were individually MRI compatible, say of ICD or something, but together they haven't been found to be MRI compatible, you can still, anyway. Yeah, something that's not MRI compatible.
Mm-hmm. And are there some things which are almost always not MRI compatible?
Because like pacemakers and ICDs and stuff, they're becoming more and more commonly compatible now, aren't they? But I don't know how frequently this is the case that they're completely incompatible or vice versa. And it's the same as like prosthetic, like hips and joints and stuff like that. I don't know if it's just a case of older ones are and newer ones are. I don't know.
I think the general consensus is if unsure, like seat manufacturers' guidelines, pacemakers, it would be sort of speak to the patient's cardiology team about defunctioning it or checking it. As we say, a metallic intraocular foreign body or shrapnel. So especially with welders, you've got to ask if someone's been doing welding. And
or working on a lathe.
Or working on a lead. The MRI unsafe ones are neurosurgical clips and cochlear implants. And then there are many of them, like pacemakers, BP shunts, neurostimulators. They can be conditional, and it depends on the specific device itself. And generally, MR safe are artificial heart valves, stents, and orthopedic implants. But I think the long and short of it is, it's to identify that they're there and discussing the safety of the MR responsible person who can access the guidance to see what conditions that these devices can be under. And it's especially important for patients who can't give an accurate history, such as ICU patients. And sometimes there may be a need to do sort of a scout X-ray to see if there's any ferromagnetic objects that come up prior to going into the MRI suite. In terms of pregnancy, the common recommendation is to avoid it in the first trimester because of unknown effects, but no one really knows what, like that. There's been very limited evidence or studies done about the effect of being in an MRI environment, but potential risk might be the strong magnetic field, excessive noise, and unscavenged anesthetic gases if the patient needs to be anesthetized for the scan. Gadolinium. What is gadolinium?
It's used for as a contrast agent.
Mm-hmm. Oh. Sorry?
It's used as a contrast agent for MRIs.
Yeah, brilliant. Any kind of things that we need to be sort of aware of? Like
renal function, maybe. I don't know if it affects your like renal function or liver function or similar.
Mm-hmm. So yeah, it's renal failure because it's renally excreted. So it becomes an issue especially in patients with end-stage renal failure, and sorry, you can look at that. So it's an IV contrast, as you say. It's renally excreted, and the side effects from it would be in end-stage renal failure, where you get nephrogenic systemic fibrosis, where you get fibrous tissue in skin or muscle, especially cardiac muscle. It's quite rare, but it's always a risk-benefit discussion, especially if the patient's creatinine clearance, the GFR, is low. And the other thing that can happen is anaphylactoid reactions, which are still reasonably rare. And common side effects would be nausea and vomiting or mild pain on the injection of gadolinium. In terms of precautions that we take to minimize risk associated with MRI, I've broadly classified them into people, equipment, and the environment. And this is sort of after the pre-checklist is done, and we're going, like, practically going into the MRI suite. So we've mentioned pregnancy, we've mentioned the checklist, and ear protection, because the MRI for patients under anesthesia as well as avoiding taking any ferromagnetic objects like pens. I've accidentally brought a pair of keys round in before, and it kind of floated out of my pants, like my trouser pocket, and it was, so I took it off. Or like even hairbands, which causes your ponytail to float. Fine. Who do you think would be most appropriate to do an MRI? Like who do you want in your team in terms of skill sets, or from an anesthetic perspective?
I mean, yeah, you'd want an ODP, a runner, and you'd want possibly a senior nurse to run the order of patients, I guess. I'm just listing who's normally on the list here.
And in terms of which anaesthetist would you have?
Oh. Senior?
Yeah. Someone who
Generally,
knows well where everything's kept and what the processes are.
Because I suppose it's it's remote anesthesia, I guess. So you'd want a high level of comfort and independence, because you're going to have a delay to getting a second pair of hands there.
Definitely, that's a good point made. The AAGBI guidelines is that it's appropriate experienced anesthetists, so they have to be familiar with the MRI environment and as well as remote site anesthesia. They should be provided, all of us should be provided training, and as well as an anesthetic assistant who is appropriately trained and familiar with the MRI environment. Generally, they say it's recommended that it's the consultant that does it. But if it's delegated to a specialty trainee or a SAS doctor, then they need to be appropriately experienced in the MRI environment as well. And there's a strong caveat that inexperienced anesthetists should not be asked to manage MRI patients, especially out of hours. So a lot of it's about having the right people in an unfamiliar place. Having the right people in a remote place to give a suitable anesthetic. Next bit we're talking about is equipment. Has anyone here done an MRI transfer before or done MRI lists?
Yeah, I think I've done one MRI list here.
I've never done MRI stuff.
Was there a pediatric list?
Yeah, there was one ped, and then there was a couple of adult learning disability patients that needed an orange juice based pre-med.
Fine. So my experience is sort of as similar, very limited. I've had one pediatric MRI list here, and then I've not done any MRI ICU transfers and stuff. Do you recall what sorts of kit is needed, and how is that different from, for example, a CT scanner?
Yeah, I mean there was a different ventilator that we connected up to, and I was looking for like a D circuit, like Mapleson D. But it wasn't. It was just a separate anaesthetic machine. And yeah, I think it was the monitoring was telly.
Yeah, I suppose it's all MRI. So
Yeah.
like your ECG leads can't have any metal, and the ECG electrodes can't have any metal, and the pulse has to all be fibre optic and stuff, doesn't it? Yeah, because you don't have any metal in there at all.
Yeah.
Yeah.
And you got the little cage thing, the tube. What is that? That's the Tesla.
Oh yeah, the waveguide.
Oh, the Faraday cage.
Faraday cage.
Yeah.
Tesla.
Yeah. Did you run your circuit? Did you keep the ventilator in the room? Or
Yeah.
Fine. So the ventilator MRI.
So the ventilator was next to the patient.
Oh, fine.
So it was just like, and then you go out.
I was going to say, did you learn about having circuits?
Yeah. I was like,
Unlimited.
where's the D circuit? Like running around the hospital, but no.
Yeah, so you've picked up lots of the things like the big kit, the anaesthetic machine, the monitoring, as well as the whole like Faraday cage thing. How I tried to, so in essence is ensuring everything is either MR safe or MR conditional. In terms of kit, everything is classified within safe, conditional, or unsafe. It like the small, lots of these things, like generally the ODP sorts as well because they are familiar with the environment, and so that's why it's really important to have someone who's familiar with the MR environment. Tracheal tubes have the pilot balloons to see whether the cuff is up, and those pilot balloons need to be taped down because it contains a ferromagnetic spring and will float around if it's not taped down, taped away from the area being scanned as well. If it's an ICU patient, a trachea tube may not be MR compatible, so we need to exchange it for a plastic one. And as with any kind of anesthetic intervention, where the airway access is difficult, then we need to ensure that the airway is secure. Otherwise, it might be like SIM for last week, where there was the prone patient, the tube falling out. The other things of kit is the big kit, as you mentioned. The anesthetic machine or the ventilator needs to be MR safe, and the vaporizers need to be MR safe. Gas cylinders on the anesthetic machines, as well as the trolleys, need to be MR safe or MR compatible with no random oxygen cylinder there. In terms of lines, we need to sort of have extra long lines, and if, for example, if an ICU patient is on vasopressors and art lines, as well as capnography, and they pass through a waveguide into the MR control suite. So a waveguide's, what I understand, is sort of like a hole or a tube in the wall which connects the MR machine towards the control suite. And it's worth noting that there will be a longer delay for the capnography, around 20 seconds, 30 seconds, as well as damping can occur with the arterial lines. The pumps are often not MR conditional, so they need to sit in the MR control room with super long lines going to the patient. So there are risks of lines leaking and other things like that we need to be aware of. Other equipment, as Kath mentioned about monitoring, everything is generally telemetric, so it's wireless. You need different NIBT connectors. Electrodes are generally placed off in the middle of the patient's chest, so sort of where you would do CPR, I think, and they're of different electrodes, as well as a different type of fiber optic pulse oximeter. And if there are any cables, then we need to ensure that they are down the middle of the patient and the cables are not looped or throw around each other because they can they can generate like currents within the MRI scanner, and they're not directly touching patients, and the cables are not damaged. Fine. And the last bit is the environment. So how I classify that is about being in the environment of the MRI magnet, as well as having radiofrequency things, radiofrequency currents around. Lots of this was previously mentioned. Things like not having any ferromagnetic materials, using a checklist, having fiber optic leads, ear protection, and this thing about quenching I will talk about in a bit later on in the presentation, and the rest of it's having appropriate equipment. Oh, yeah. So as in terms of the equipment, oh, sorry, Johnny asked if we could talk about equipment. I mentioned about having different types of monitoring. So, oh, airway stuff. What do you want to add?
Did you use an LMA?
Johnny asked if I've used an LMA. Yeah, we used an LMA. I used an LMA when the kid was to be anesthetized. I think all the airway needs to be like MR safe airways. And
the specialist LMAs. They have a non.
Hang on, I'll just pass this.
Yeah, sure.
Okay, what do you say?
That's a specialist manager.
Oh, okay. Basically, we need a specialist LMA if the patient needs to be have some kind of airway adjunct and tubes. And as we alluded to earlier, the location of the MR suites far away from theaters, so calling for backups not as easy. And when the patient's within the scanner itself, it's difficult to access the patient. Yeah. Here's a couple of videos that I'm going to share about. Hang on, let's see if this works. Okay.
Yeah.
Screen window tab. Is this sharing at all? Can you guys see the YouTube thing?
Yeah.
Okay. So this is a video of people chucking stuff into an MRI scanner, ferromagnetic stuff into an MRI scanner, and then this was done right before quenching. So we'll show what quenching is as well in this 1 minute video.
Oh, he's almost got it. Don't hurt yourself. Yeah. Rob can do this.
How many years has it been here?
Since 91, 92.
How long have you been here, Fred?
We're not talking about that.
That's just quench. That's the next thing.
Never been on.
We're going to have major healing.
Yeah.
Tack, though.
No, it's frozen. You can take a hammer to it.
And the quenching outlet goes out into the environment, so that's vaporized helium.
I missed the party?
Yeah, so that short clip shows the dangers of an MRI scanner if incorrect equipment's brought in. What am I trying to do? Let's try to do this. 11. Let's close screen. That's better. Fine. So sometimes there may be medical emergencies, and having a medical emergency in our MRI scanners is logistically not possible. So what you do is to bring the patient out and into the induction room, which is in Esch, sort of round the corner from the MRI scanner itself. And that's where you can get the resuscitation equipment and drugs. You can have the radiographers to direct the rest of the resus team away from the MRI scanner and towards the induction room where resus can take place. And yeah. So quenching, have any of you heard of what MRI quenching is?
It's like an emergency shutdown, isn't it?
Mm-hmm.
It's not very good for the scanner.
No.
It's very expensive and damaging.
Yeah. Yeah, and Dr. Diamond says, is it when all the helium escapes, which basically it is. Quenching can be done sort of electively or by an accident. For example, if there's a system fault, the MRI scanner is kept, like the magnet is kept up with a superconductor of a liquid cryogen, which means liquid helium often, and that's super cool to near absolute zero to maintain the MR magnet. And when quenching happens, it means that there's a rapid boil off of the liquid helium straight into gaseous helium. So there's a large volume expansion, and this must be vented very rapidly. So there's usually a venting quench pipe within the MR suit to vent this outside of the building, which is what we saw earlier in the clip. There was a pipe above the MRI scanner, and it vents the helium out into the environment. And quenching sometimes, so there are safety things within the MR suite which sort of detects if there is an inadvertent spontaneous quenching, MRI quenching. Because if the quench pipe is blocked, that means the MRI room becomes a hypoxic environment because it fills up with helium. So in the MR suite, there's oxygen sensors, pressure equalization systems, and ventilation controls to help alert staff and evacuate appropriately. I think each sort of MR unit would have their own emergency quench protocol, and staff should be aware of it. I'm personally not aware of the one at Esch, but I think there should be one, or there is one. Yeah, and so we've come to the end. We're doing lots more MRI scans, and in essence, it's important to identify sort of pre-existing contraindications even before going to the MRI scanner. So things like foreign bodies, checking devices are compatible or conditional, and what conditions they are, as well as the patient's renal function if contrast is needed. And there are challenges relating to MRI being in a remote environment with strong magnetic fields. So having the right people and correct and familiar with the environment, having the correct kit in terms of the anesthetic equipment, the large heavy equipment, but also monitoring and the airway kit, and knowing who to call.